why it happened. They didn't know what it was about. And you know what? So it's no wonder then if the people who are doing the research, the people who are, well, because they're doing research on drugs, but the people who are writing the articles in the journals don't know what's going on. How do you expect your doctor to know what's going on? They're reading the journals and then they're going, this is what they said, and this is all I've ever heard. And so, you have to go into things like for example, I had somebody I gave him this um, little dibujo. It's a graphic of cholesterol, and along this side is the level of cholesterol. And I mean, I'm sorry, on this side it's the death rate, and on this side is the level of cholesterol. And so the death goes up when you have lower cholesterol, and it goes down when you have higher cholesterol. And so the optimum cholesterol, look at the lowest death rate is right in here, and that's 200 to 240. Like 230 is like a perfect place to be with the absolutely lowest death rate from with the cholesterol. And that has been shown in multiple studies. Even the old study, this is called the Mr. Fit study that was done in the 1990s. You see that same, the blue is the all-cause mortality. You see that same as the cholesterol drops down, the death rate goes up. Um, and so I showed him that graph, and he said, I want to bring that to my cardiologist because my cardiologist needs to know this. And so he did, and he came back and he told me the cardiologist threw it in the trash and said he'd never seen it before, that it probably wasn't real. Wasn't real. This is like 12.8 million adults. This is the largest study ever done by far, by millions. And it's just crazy that nobody's seen it because it's written in a science journal and not in a medical journal. So what we're talking today is science. This is like what it is. What is heart disease? Because we already just showed you it's not cholesterol. That's not your issue. And then we have another one on blood pressure. This is an interesting one too. Everybody says, "Oh, my blood pressure's on. My muscles are going to pop. I'm going to get a stroke. I'm going to get a heart attack." That's not the way it works. This is the diastolic blood pressure. You could be anywhere from 60 to 90, and that's the one time the average death rate. And your systolic, which is the higher number, optimum is right here, 140. Look at that. So 140 over, actually the lowest part here is like 75. 140 over 75. That's the optimum blood pressure. Um, and unless you're in your 20s, then actually if it gets down to 110 or 120, that's perfectly fine too. So what is the science, and what causes heart disease if it's not going to be like cholesterol and blood pressure? Then you have to look at, okay, what is it exactly? What's going on? And so we look at heart disease from several different angles. One is the blood vessels. What is happening in the blood vessels? Well, what happens is you get clots. That's what's clogging the arteries, is clots. And when you get a clot in the wall of the artery, then it can grow and clog up the entire artery, and then you don't have blood flow to that area of the heart, and that's what a heart attack is, when the blood stops flowing, and it stops flowing because of clots. Now you can form little clots in there, and they can repair, and you wouldn't even know it. But some people form more clots, or they don't dissolve the clots that they form. So everybody makes clots periodically all over the place. But most people will repair that really quickly, like seconds, like really quickly, and then dissolve the clot over time, over a period of weeks, like usual. You get a cut. How long does it take to repair that and dissolve the clot? It's going to take a couple of weeks, and that's normal. But if it doesn't, then you end up with this clot that's called organized. And the organized clot means it's scar tissue. And the scar tissue has calcium in it. And so I recommend people do a coronary calcium score. Why? Well, that's telling you if you have clots that are not dissolving and they're organizing and forming this scar tissue in your arteries, that can get bigger and bigger and clog your arteries, then form a clot and plug up completely, and you end up not getting the blood flow to your heart. And it's not just the heart; it can happen to any blood vessel. What is a stroke? A stroke is a clot. It's a clot that goes up into your brain. Well, if it's in your heart, see that thrombosis means clot. That's what it means. Thrombosis is a fancy word for clot, blood clot. And so, you don't want clots to happen inside your arteries and veins. That's a terrible thing to happen. But it does happen, and your body has a very good way of cleaning it out as long as things are working properly. So if you have a lot of inflammation, then you're going to make clots a lot more easily. And if you have a high level of lipoprotein A, then you're not going to dissolve clots very easily. And if you have high inflammation, you also don't dissolve clots as easily as well. You have more fibrin split products. You're more likely to form clots if there's any damage, and then it's less likely to dissolve. It's more likely to form more and more clots. So when you look at it from that point of view, then it becomes obvious what to do. Oh, I don't need to worry about cholesterol. That's a red herring. That's something that people spend a lot of their time doing without diminishing their risk for heart disease. And then, so what is it that you do need to do? And that's, you have to stop clots from forming and dissolve clots. That's like, oh, okay. So how do I do that? Well, that's what our program is all about. How do you stop clots from forming? And that's like getting rid of inflammation, getting your nutrients balanced. And then how do you resolve when you do get clots? How do you dissolve them and repair well? Well, part of that is something we talked about last time, is stress. If you have a lot of stress, that raises your cortisol levels, and cortisol prevents you from repairing the damage that's been done because it puts you into catabolic mode. Catabolic mode is when you're breaking down and making things worse. Your tissues break down, everything breaks down. Cortisol. Did you know when they put a cortisol shot, like I've had people with rotator cuff tears and all that, and they go into the doctor and say, oh, my shoulder hurts, I can't lift it up. Here, let me put a shot of cortisone in there. So they put a shot of cortisone in there, and what that does is it kills all of the cells that cause inflammation. And people go, wow, this feels great. Well, it also kills all the cells that repair the damage. So now you have weak connective tissue. You don't have the ability to repair it because of the cortisol. Or cortisone injection. So a lot of responsible orthopedic surgeons and people that work with joint pains and stuff will tell you, nope, not putting any cortisone in that. We gotta fix that from the inside and repair that, and not put shots in there, because that stops the healing from happening. And it also makes the tissues what's called friable. They don't have strength anymore. They're just weak connective tissue. So if it tears and they want to put that tendon or ligament back together, there's just nothing to stitch to. It just won't. It'll just fall apart. So for those reasons, cortisol is bad for your heart as well. It's not a small thing. In our book, we dedicate quite a bit to lowering stress levels. And if you look at the supplement that we have, it has ashwagandha in it. Why? Well, because that lowers cortisol. It doesn't suppress cortisol. What it does, it's an adaptogen that prevents the excessive amount of cortisol being produced from stress. So um, that's the basics. Like that. It's so simple. You go, oh, that's something that we can fix. That's something that we can handle. We can prevent heart disease. We can reverse heart disease. We can repair the heart. And so that's a good portion of what's going on.
Love it. I love this. We're getting some questions coming in. If you have questions, post those in the Q&A. Again, that's just the best place for us to manage those. I want to read this information from Don. Don said, I am a 76-year-old male. At 71, I had a calcium score of 0. What should a calcium score be, Dr. Saunders?
0.
Okay. Recently, I had blood tests done after fasting for 12 hours. Cholesterol 239, LDL 169, HDL 43, triglycerides 148. What is the best thing I can do to improve these numbers?
Okay, great. Those are all great questions. So your cholesterol is perfect. Don't change a thing. The cholesterol between, like I said, between 200 and 250 and the 230 seemed to be the optimum place to be. So that's where you want to be. So that's good. Your HDL is a little on the low side, and your triglycerides are a little on the high side. So the best thing you can do is avoid sugar, especially fructose. Which will, if you're not eating fructose, then you will start burning fat for energy, and your triglycerides will drop down. And then your triglyceride HDL ratio will come more. You should have about 1, ideally. The amount of HDL to triglycerides should be right about 1. And that is optimum. But look at it this way: you don't have heart disease. You don't have it because you don't have coronary calcium score. And there was a good study done, long-term study, showing that people with coronary calcium score of 0 do not need, well, statins is what they were looking at in the study. Because there's no benefit to that. That's not your issue. So, it's really interesting. If you were to go in with those numbers to a cardiologist, the cardiologist says, oh my gosh, your cholesterol is high, you got to go on this statin, not knowing the research about clots and stuff like that. So you're not a clotty person. And if you are a clotty person, then you're dissolving all those clots. So you're doing really well. And so the only reason I would say about the triglycerides and the HDL is that's a metabolic issue. So that's not a heart disease issue. It's a metabolic issue. So if you want to have really good energy metabolism, then just cut the fructose out, and you'll see that HDL to LDL. And you should probably add in fish oil. And you'll see that HDL to triglyceride levels equalize, and your HDL will come up, your triglycerides will come down, and that will be a metabolic benefit because you'll be able to burn fat for energy better.
Don said the doc fights me all the time about statins.
I know, but you know what? The research, this is unfortunately it's scientific research, and so they don't print it in medical journals because medical journals are paid for by drug companies. And so, the people that make statins are not going to allow something like that to be printed in a medical journal. So, that's why that's hard. But also, you know what? You just, I think the best way to deal with doctors is go, oh yeah, smile and wave, and then go home and just leave it on the shelf or throw it in the trash or something.
Well, it is funny. I have some conversations with some of the people that are on the webinars here, and I'll ask them, do you have other health issues that you're dealing with? And they'll say no. And then later on in the conversation, they'll be like, oh yeah, I'm taking a statin. It's like it's so normal that, and you've said that, Dr. Saunders, that it's handed out like candy, and they wish that it was in water. And so people kind of even forget that it might even be a big deal. Are there side effects to these statins?
Oh yeah. Alzheimer's disease. You don't repair as well. Cholesterol is really important. You age fast if you're taking statins. I definitely would not use it.
Okay. All right. Let's dig into some more questions here. Also, I was going to mention, I think he recommended to you, Don, no fructose or sucrose. What did
Fructose. So
okay.
sucrose has fructose in it. So you got to avoid that too. Honey has fructose in it. Agave nectar,
Probably
uh,
best if you don't look up all the things that it's in.
high fructose corn syrup, and then you got to be careful of certain fruits, apples and grapes and mangoes. There are certain fruits that are pretty high in fructose that you should minimize, and then eat the fruits that are low in fructose. Wait a minute, I think oranges are higher in fructose, apples are less high in fructose. So anyway, just cutting most of that out, the fructose out, is actually a really good way to get your triglycerides down and your HDL up.
All right. Ron said I had a total calcium score of 785. Okay. So total calcium. So normal we just said was 0.
Yeah, normal is 0.
Okay.
High is 100.
Okay.
400 is really high. 700 is really high.
Okay. Okay. And Ron said, I wanted to repair my damaged heart. It looks like fasting is the best way. What length of fasting would be best for me? I'm 5'9", 160 pounds.
Okay. 5'9", 160 pounds. So you're not overweight. So the best kind of fasting would be like 3 days once a month, for that kind of thing. Why 3 days? Because if you do less than 3 days, then you don't get significant autophagy. Autophagy is where you're eating yourself. Auto means self. Phagy is eating. So you're eating up all of the dead tissue, taking out the dead cells, and it's really cool the way this happens. You have this cell that's all crenated and not working well, and it just sits there. It's a senescent cell. It's still there. And when you start autophagy, then the white blood cells, phagocytes, come over and they totally engulf this cell. They totally all the way around it, and they pull it out from where it is, and they digest the whole thing. And because they have digestive enzymes, and they spit out amino acids, for then you can use the amino acids to make proteins from other cells, for other cells. And it's like really like you're eating your own self, but all of the dead stuff. It's clearing out the dead wood. And that's why autophagy is really important. And part of that is the deposits in your arteries. Now, remember, it's scar tissue, the calcium deposits. So when you have a score of 700, the calcium does not just go out by itself, and the scar tissue doesn't go away just because you fasted a few times. I had a guy do a 30-day fast. His calcium score was 1,000. It was 1,000. So he was really high, and he did a 30-day water fast, and he's, I'm going to clear out those arteries with this autophagy and all that. And then so he, after a couple of months later, he retested, and it was 1,200. And he was so upset because he thought he was cleared out all his arteries and everything. But what happened clinically is he got all better. Whereas before he was having chest pain with exertion, now he had no chest pain at all and was doing really well. So he fixed the problem of the flow through the arteries. That was all okay. But those calcium deposits were still there. In fact, there were more calcium deposits. Why? Because as the plaque that's there calcifies, then you're building up calcium as it's organizing. You're building up more calcium. So he organized all the clots and everything. He got more calcium than when he started. But clinically it was better. But he was so discouraged about the coronary calcium score did not come down with fasting. So Don't expect that. That's not the way things work. It's not that simple. But there is some evidence that you can pull calcium for calcified arteries, not necessarily the scar tissue, but the calcified arteries. You can pull calcium out with vitamin K, K2, and you'd need more than 300 micrograms a day. So, yes, I agree. Fasting would be a good idea and enough to get autophagy. So 3 days in a row, once a month would be a good idea. Oh, autophagy.
Thought
There
I
you
would just
go.
share this because you can see that membrane that forms. It's kind of like Pac-Man. It's eating it.
Yeah, it eats it and then spits out the all of the amino acids and everything for you to continue using as if you were eating food.
Wow, very interesting. Okay. All right. Let me see. Okay, did that one. Beverly had said, don't forget hemorrhagic stroke. Tell us about a hemorrhagic stroke.
Okay, so a hemorrhagic stroke is a different kind of stroke. So when I started, I was talking about clots and arterial disease and how the arteries build up these clots over time. And then there's another issue, which is a completely different issue for a completely different reason. And that is when you have weakening of the walls of an artery, you get a hemorrhage. And hemorrhages happen all the time, all the time. In fact, if you've ever heard of warfarin, that comes from coumadin, which is a rat poison. And how did it work in rats? Because the rats would eat it, then their blood vessels rupture in their brain, and they wouldn't stop bleeding, and they would just die of internal bleeding, hemorrhaging, and that's how it worked. So. Since we do have blood vessels rupturing all the time, then they have to be repaired. And that's why it's so important to be able to form clots. And you can get a hemorrhage anywhere in your body and you're not even going to notice it almost anywhere. If it's in your skin, you'll see a dark, and you go bruising, you go, I don't know how that happened. Sometimes it's random and just spontaneous. Sometimes it's, you bumped something and broke a blood vessel, but blood vessels break. If you've ever seen like people in their eye, the whites of their eyes, and it gets bright red, and you're like, oh my gosh, that looks horrible. Like, what happened to your eye? And it's like, it's a hemorrhage. It's a stroke, essentially, in the white of the eyes. And it's just that stark white to red contrast that makes it like, oh my gosh, that looks horrible. But it's not a problem. It's just normal. It happens all the time. But if it happens in your brain, in especially certain areas of your brain, then it's an irritant to tissues and it causes damage, and it can cause a clot to form and stop the blood flow. So there's the hemorrhagic stroke, which can do damage to the brain because of bleeding into the brain. See, when it bleeds under your conjunctival membrane in your eye, no big deal. If it bleeds under your skin or in your muscle, nobody cares. Nothing's going to happen. But when it's in your brain, it becomes a big deal. So yes, there are hemorrhagic strokes, and some people have what are called aneurysms, which is a balloon. So you have this blood vessel, and it has a balloon coming out of it, and that ballooning is called an aneurysm, and they can be really thin-walled and they can pop and cause a lot of hemorrhaging and a really bad problem. So yes, there's hemorrhagic strokes too, but that has nothing to do with what we're talking about with heart disease. That happens anywhere, and even happens in your heart, and you won't even notice it.
Interesting. I just found a picture of an aneurysm too. I'm going to give you all the visuals here today. I feel like that's how I learn best, and Dr. Saunders explains things very well, but it's just kind of interesting just to see, this one's an aneurysm in the brain, but
yeah, there's the aneurysm, a little balloon there, but it's very thin walled, and so it can pop.
Very interesting. Okay. All right. Shirley, welcome back, Shirley.
Surely you must be kidding.
Shirley, Shirley, right? Is Shirley the one that you know, Dr. Saunders? I was
Yeah,
thinking,
I
you
don't know.
treated her like in the 70s or 80s, like
yeah, I think
a
so.
long time ago.
Yes.
Oh,
Um, okay, Shirley says if you have a healthy heart, wait, if you have a healthy heart, yet get pressure in your chest and have poor circulation and popping veins, what is the issue?
okay. So if you feel pressure in your chest, and if it's a heart thing, you can have perfectly normal arteries. And when you're under stress, when you're making a lot of adrenaline, epinephrine, norepinephrine, you can have constriction of those arteries that stops or slows down the blood flow enough for you to get chest pressure. So that could be a heart issue. There are other reasons for getting chest pain and chest pressure too, though. You could have spasm of your esophagus. So if you have acid reflux, then it's irritated, the esophagus, it's irritated, and then it spasms. And when it spasms, that will feel like pressure, substernal chest pressure, and it's indistinguishable from a heart attack. And a lot of people going into the emergency department, they put on the EKG and they say, "No, your heart looks okay. Must be your esophagus." That. But there are other muscles in the chest, but usually if it's like between the rib muscles called the intercostal muscles, or like you said, that popping that you feel, that's usually called costochondritis. And that's inflammation, it's called. It may not be inflammation. It might be just a lack of blood flow to the cartilage parts of your ribs, and then your muscles, and sometimes you can even feel a kind of crepitus under there, like it's kind of poppy from the inflammation. So, and tender, and usually you'll notice that because it's tender, as opposed to the others where, like, if it's heart or it's esophagus, yeah, you're not going to notice any tender. You're not going to be able to push on it and go, "Ow, that hurts." It's going to be like, no, it's deep inside.
All right. These are good questions. You know what? I want to quick make a mention since we're about halfway through here. Cheryl, will you chat about home cures that work again? I want to bring that up because I know that some people are finding a lot of benefit from that.
Sure. So Home Cures That Work has been around for, oh my gosh, 17 years now. It's actually when Dr. Saunders was kind of brought onto the Barton team to write for Home Cures That Work. So he's been writing an article every month for the last 16, 17 years. And so we used to do it by topic. Every month would be devoted to a topic. Now it's a variety of subjects, but it's a free website. You can go. You used to have to require membership, but Dr. Saunders has an article every month you can read. This next coming month is going to be on keto. So if you guys are thinking about keto for your heart health or keto for your blood sugar, you're going to want to read that. And so it's like, I always kind of look at like an encyclopedia. If you have a question about a natural health issue, go in there. You'll probably find an article. We've talked about cholesterol for years and years and years, actually. And so many, I feel like Home Cures at Work was before its time. Like, we were talking about natural health years ago. So now you can find, and some people didn't believe it back then. Now it's starting to become more mainstream. So you can find those articles and grow in your knowledge and hopefully in your implementation of trying to improve your health.
Love it. That was great. And Cheryl, what's your role with Home Cures That Work?
I'm sorry, what?
What is your role with Home Cures That Work?
Oh, I just put it all together.
She's the publisher.
Kind of the most important part.
I went back and read some of those articles. I was looking up something, and I'm like, wow, that's pretty good.
Really
because
good.
when I go through it, I research it. I'm looking for, why does that happen? Why does that happen? And yeah, it's pretty good.
One of the most read articles were about dehydration. Like, who knew that it was a big issue with people? So now everybody uses electrolytes, but we were talking about dehydration a long time ago. So if you're thinking about, what do I need to stay hydrated? Do you need to stay hydrated? Go look up dehydration.
And Cheryl, would you mind posting a link to that in the
Sure
chat?
will.
And I'll share that on YouTube also. Dr. Saunders, this has made me think of something else. A couple of times you've mentioned, that you do a lot of research on things. I know, okay, so for example, my dad's a realtor and he has to do so many hours of continuing education. My sister is a hygienist, dental hygienist. She has to do so many hours of continuing education. How does that work for medical doctors?
Oh, it's about the same. We have to do 25 hours a year of continuing education. And so I did 2 hours this week. You know, I told you about my 2 hours of diabetes research and how disappointed I was in the education. And I actually told them that on you know, you have to give them a, um, a review. And in my review, I said, you know, this would be a lot better if we had more of the scientific information.
So, but you're doing a lot outside of that. You're doing your own education, figuring a lot of things out, doing a lot of research. How typical is that? I mean, from what I'm
Oh,
hearing, not typical.
it's not. It's not. Okay, so we have this issue now of cookbook medicine, and it started 20 or 30 years ago, where they have an algorithm for everything, and the idea is to make it simple for everyone. Someone comes in with high blood pressure, then the number one thing to do is start on this medication, beta blocker or whatever. And then they come back, their blood pressure is still high. They should be started on an ARB. And then their blood pressure is still high, then they should be given a calcium channel blocker. And so everything is spelled out in an algorithm. And if anybody who follows the algorithm is safe, you're safe. So it's all about safety. You can't be sued for following the algorithm because that's what everybody does. That's what's expected of you. You do what's expected of you. So, for example, I give the extreme case. Let's say someone's an oncologist, and this oncologist A, has 10 patients with cancer, and does the standard treatment, just like chemotherapy. Everybody gets the standard treatment, and 9 of them die, and 1 of them survives. Out of those 10 patients, 1 survives. Then that doctor is a hero because 1 of them survived the chemotherapy, and so he's marked as a hero. So then another oncologist says, well, you know what? It doesn't really work that well. I'm going to do something different than everybody does. And so she's giving her patients IV vitamin C treatments and combination treatments, and using repurposed drugs, and getting rid of the metabolism of the cancer. And 9 of them survive and 1 dies. She could go to jail. She could go to jail because 1 died and she didn't give the standard of care. So that's the way the system works. And if you go to a cardiologist, it's the same thing. They cannot go outside of the algorithm. The algorithm is everything. And so that's why you can go anywhere in the world, in the United States at least, Canada, and get the standard of care and nothing else. So you can't get individualized treatment. And if you ask your doctor about some of the things we talked about clots, and how do I prevent clots, and what is this LPA, what does it do? They're going to say, nope, nothing there, nope, nothing there. And that doesn't matter, that's nothing, because it's outside of the algorithm. So what I do, instead of looking at the algorithms, but I have to go to CME courses to hear that stuff, because they're all taught by drug companies. So so what I do is each patient that comes in is a separate individual. And so I'm doing research for that patient. So last night, I was a couple hours after work, I had somebody come in, or just got her test back, actually, that was showed that she had a certain kind of lymphoma that is really rare, called Waldenstrom's macroglobulinemia. And so I started researching on that, because I've never had a case before, ever. So I start researching on this type of cancer. What's the best way to handle it? What's the current standard of care? What's being done? And so I know what the oncologists are going to offer. And then what else is out there, and what is it related to, and what type of metabolism does it have, and how can you, what are repurposed drugs that would be good for this? And so I came up with a protocol that included the standard of care cancer treatment, because it looks like the one that they're using actually does improve this, but it has side effects. So we're going to use Nervala to prevent the neuropathy side effects. And then we're also going to use some repurposed drugs. Sirolimus is used to prevent people from getting making antibodies against their transplants. So it prevents transplant rejection. And so what is transplant rejection? Well, that's making antibodies against your graft. And what's the cancer? Well, that's making antibodies too. And so we're going to use that. So we're going to use some repurposed drugs that aren't normally used. And so, developing the protocol. So I learned a lot in the process of searching out this very rare cancer and how to treat it.
Wow.
That's
So
how it
cool.
works.
That's why we appreciate you so much, because you're willing to do this stuff, and I'm pretty sure you would really enjoy doing this too.
Yeah.
Every time I see you,
I
enjoy.
do. I love it, so I stay in it. But I've had my license revoked twice. The medical board does not like what I do at all. I get reported to the medical board by cardiologists for taking people off cholesterol medications. I get all these issues because I don't do the standard of care, and that's essentially why, when they revoke your license, it's you're not doing the standard of care, and so.
And their goal with that, I mean, hopefully, is to keep people who are doing bad things from doing bad things, I'm assuming. Yeah. But then you kind of wonder how you fit into that, and how people like you can fit into that. And that's hard.
It's hard. It's hard. Yeah. If you're outside the norm for anything, it's hard. No matter where you are, no matter what business you're in, if you're outside the norm, it's hard.
I mentioned this yesterday on our webinar, but I think it's good for you guys to know too. There are so many things we can't say or do or email you about. There are certain words we cannot say to you guys, or we just get shut down, which is so sad.
Yeah, we can't use the C word or the other C word or the other C word.
Many of them. Yeah. Anyway, okay. So let's keep going here. We got more questions. Let's see. Beverly says Dr. Pescor does talk about sticky cholesterol, which he says is a problem. He says they measure it in Europe.
Yeah. So that's the idea of these fluffy LDLs and the sticky cholesterol. ApoB is kind of it's not a direct measurement; it's an indirect way of looking at it. Do you know what though? The problem is still not the cholesterol. Yes, people get fatty streaks in their arteries, and that's true. But the problem is still the clots, and no matter how you look at it, the cholesterol is not the issue. I had somebody that's really interesting, had a cholesterol of 325 or something. And she was like, oh my gosh, she told me that her cardiologist told her, like, oh my gosh, you're going to die any minute now if you don't take this cholesterol medication, this statin drug. And I said, well, have they done a coronary calcium score? No. Okay. So we ordered a coronary calcium score. Guess what it was? 0. She goes, but what about that? How can I have a cholesterol of 300 and have 0 calcium? Because you're not making clots. That's the issue. It's, the issue of deposits in your arteries is not related to cholesterol.
I'm trying to get Cheryl back on here and I don't know why it's not working. So I'll try that again here in a little bit. Let's go to the next question we have here. Oh, she's back. There we go. Okay, Shirley said I had 2 of those shots when I had surgery on chest, breast for a burn, worse than 3rd degree with fat cells of breast. The scar was very bad and breast never grew back where it was. Oh, cortisone maybe.
Yeah. Yeah, it could have been cortisone. But that's like a different purpose. Yes, it will inhibit healing. It'll slow down healing from the cortisone, but getting the inflammation down is important too in a burn victim. So yeah, there's like conundrums that form here. You want to get inflammation down, and cortisone is the best way to do that. On the other hand, it will also stop healing. And so what I'm talking about is mostly the chronic stuff, like people who have, rotator cuff tears for a year and they're getting cortisone shots and stuff like that. And instead of healing the problem, or people who have diabetes who are taking cortisone, that, is going to make them more insulin resistant. So those kinds of things are not a good thing. But with an acute injury, burns, stuff like that, I don't know. It's not that easy. You've got to get the inflammation down, and sometimes that's what's required.
Okay. Well, Shirley did mention that she used to see you in Solvang, and Shirley, you remember her.
Oh, surely I remember. Yeah, I'm in Solvang right now.
And you gave her garlic instead of an antibiotic.
Yeah.
That's funny. Okay. Beverly said, can my recurrent severe iron deficiency anemia be affecting clot formation?
Okay, severe anemia. The anemia by itself doesn't affect clot formation. You might expect you have to have more circulation, so you have a more rapid heartbeat and faster circulation. You're less likely to get clots in that kind of a case, as opposed to a sluggish circulation where you get more clots. But the anemia by itself isn't necessarily, it won't cause you to have more clots. But you have to be kind of careful with that, because not getting enough oxygen to tissues can cause inflammation, and that inflammation can bring more clots. So it's not a direct thing, but there may be an indirect reason for that. The other thing is why? Why do you have anemia? Because if it's a sickle cell anemia, yeah, you're going to make a bunch of clots. It's going to be that's going to cause vascular disease all over your body. Those sickle cells are not benign. They actually scrape up the blood vessels and cause clots to form in the blood vessels. So that type of anemia would be a bad type. Other kinds of anemia, like beta thalassemia, would also have some more issues with clots. But iron deficiency anemia probably wouldn't. So the reason for the anemia would be important too.
All right, just a reminder, I'm going through the questions in the Q&A, so if you can post those over there, that'd be great. Noel said, I heard Dr. Saunders mention fish oil. Is it true that you have to watch out for fish oil because it goes rancid?
Yes, fish oil goes rancid. So you do have to watch out. It should be refrigerated. You should use it within on the label. There's going to be a best by date, and I rarely tell people that the best by date has anything to do with anything. There's expiration dates on drugs and vitamins and all that, and most of them are like, it doesn't matter. They're good 5 years past their expiration date. Okay, fish oil is an exception. Actually, it does go rancid. Yeah, it's good to keep it refrigerated and good to use it up quickly.
All right. Kim says, I don't like the way statins make me feel. Is glucosamine, D3 and K2, COQ10, and red yeast rice and baby aspirin good together and help?
Yeah, those might help. The red rice yeast is a A statin. It's a Mevacor, essentially. That's when they figured that out, then the patent, the drug company that had the patent on Mevacor said, "Hey, you can't use that. I have a patent on it." And then the vitamin company said, "No, it's perfectly natural. It's yeast. We didn't make it. We didn't manufacture it. It was made totally natural by yeast." And so they had this big, court battle over it. And then it finally decided. So what it came down to is, according to the law, it can't be regulated if it's a natural production of a bacteria, yeast, or something, and not extracted and not purified, or not purified. It can be an extract. That's what it is. But what they said was that they can't claim that it lowers cholesterol. So you can say red rice yeast, but you can't say lowers cholesterol. You can't say that. And that was their compromise. So all the other ones are great, and they're great together, and that's a good idea. But you may not need the statin. I don't know. Look at your cholesterol and look at where it is and say, okay, what's my number? And if your number's in the 210, 220, 230, that's perfect, and you should stay off of that stuff.
All right. Wayne said, "What would HES do to my heart?" And he said, "It's hypereosinophil syndrome. It's inflammatory."
Hypereosinophilic syndrome.
And he's also been diagnosed with stage 4 critical heart disease.
Oh, yeah. So HES is not a benign condition. It's pretty bad. And when it's and it affects your life, it's not a small problem. And that needs to be treated like a lymphoma, or that blood type cancer, because these eosinophils, you could go, so a normal eosinophil count is going to be somewhere in the 100 range, right? Even down, I've had low hundreds there. 0.9 would, let's just say eosinophils 0.9. Okay, that's normal. And so the hypereosinophilic syndrome, they might have 10,000. It's like that much different. It's not just twice as much or 100 times. It's like 10,000 times more. It's like a lot of eosinophils, and eosinophils are what causes allergic reactions, allergies, coughing, all the histamine reactions come through eosinophils. So it's really important to treat that. And I first start looking for the cause, and sometimes it's parasites, and so looking for that. Anyway, that's a hard thing to deal with, and it needs to be dealt with, and it's not something that you let go. Yeah.
Oh, okay. Kim says, "Can you get off lisinopril after taking it for over 10 years?"
Oh, yeah. Lisinopril works for less than a day. You got about 8 hours of relief, and then it's gone anyway. So every day you've been taking it, it's gone. It's not something that you build up over time and have to wean off of it. It's just you're on, you're off, you're on, you're off. It doesn't matter.
Connie says, "Doctors put me on statin drugs, so I have heard that if taking statins, I should be taking coenzyme Q10. If true, what is the best on the market and how much per day?"
Okay, so start with question 1 is, do you need a statin at all? If your cholesterol off the statin is below 240, then you definitely don't need a statin. If it's above that, then you do need a statin. Then coenzyme Q10 is a good idea. In fact, I think it was Pfizer that marketed. They didn't market it. They patented a statin CoQ10 combination, where you get both the statin and the CoQ10. So the reason for that is because statins inhibit an enzyme that makes cholesterol that also makes CoQ10. So and CoQ10 is so important for energy production that they didn't want to have that be a problem. So the odd thing is they patented the formula and then shelved it and never marketed it. So that now nobody else can use it. Nobody can do that. So yes, you can take CoQ10 if you need a statin and you need to take it. Then by all means you should take CoQ10. And there's a lot of different forms of it. Well, a couple different forms. There's the alcohol form, ubiquinol, or just the ubiquinone, which is a ketone form. And either one is okay. They'll tell you the alcohol form is better, it's better absorbed, blah, blah, blah. But you know what? Just take a little more of the ketone form and it's just as good. So about 100 milligrams twice a day. And yes, get it from a reputable company, something that somebody that tests. Because not everybody tests and not everybody can tell you what's in that pill. And New York State went into several different places. They went to a GNC and a CVS and I forgot somewhere else, 3 different places, and just pulled stuff off the shelf and had them tested. And quite a lot of them, mostly the herbs, did not have what they said they were supposed to have in them. Most of the vitamins were okay, were pretty close. But like a lot of them, 60% did not have what they said they had in them. So yeah, somebody that tests before and after, good quality company.
Question here. Go ahead.
Well, I was just going to add, we work with a really high quality manufacturer for our supplements. And I think we've mentioned this before, but it's worth mentioning again. Any of the ingredients that we bring in from around the world, they are tested to make sure they're free of impurities, free of fillers. And if they don't meet our standards, we do not use them. And you know what? Other companies pick them up, probably to sell like on Walmart shelves. I'm not saying that they do, but our ingredients are stellar, and the manufacturer goes to the highest standard that they can. It's FDA approved. So you know what you're getting when you buy our supplements. And that's just a soft plug, but I'm just saying our supplements are quality.
That's good. Thank you.
Yeah, I've been to the manufacturer. I've seen the testing facility. And it's before and after. So they test before to make sure, like Cheryl said, that that the materials are the right materials, and then they test after to make sure the pill has what it says it is supposed to have in it.
Oh, we're out of time. Okay, I'm going to ask this anyway. Mary said, I have calcium deposits in some of my joints and fingers. I have osteopenia, and my doctor has me taking calcium each day with alendronate to help my bones absorb calcium to help the osteopenia. What can I do to help the calcium deposit in my fingers, as it makes my joints stiff sometimes?
Okay, so alendronate is quite toxic. It kills bone cells and should never be taken by anyone. It's really, really a toxin. That's all it is. So alendronate should never have been approved by the FDA. It kills your bone cells. That's what it does, prevents remodeling. So then taking calcium, what's that going to do? That's going to cause more deposits of calcium in your arteries and veins and soft tissues, including maybe your joints. And so the calcium deposits in the joints, it is not the problem. The problem is the inflammation in the joints. So because you have inflammation in your joints, the calcium deposits there because of the inflammatory markers, the buildup of inflammatory tissue and fluid and all of that. So the calcium sticks together and forms little crystals. And as it crystallizes in there, then you get these calcium deposits. So the fact that the calcium deposits are there means you have arthritis. So the next step is so I've gone through everything, right? Ditch the alendronate, ditch the calcium, take vitamin K2 to get the calcium deposits out of your soft tissues, put in your bones. Take vitamin D, D3 at about 10,000 units a day. And then figure out why you have arthritis. And the why is the most important thing. I had a woman that had years, over 10 years of arthritis, and her fingers were like you couldn't use her hands. They were so hard. Her joints were completely, not completely, but very stiff. And she went off tomatoes and nightshades, and everything got better. She's like, wow, I can use my fingers again. It was like really weird. And after a while, it was a year or so, she ate something with tomato sauce in it. She didn't think it would be any big deal to just have a little bit, and it all came back, and it was like she was all stiff in the morning again. So so find out what you're sensitive to, why you have the arthritis in the first place. Where is this inflammation coming from? And then get rid of that.
Good stuff. Thank you, Dr. Saunders. We appreciate you so much. We'll see you next week. Go bless your
All right.
patients.
Bye-bye.
Bye. Okay, so I know there are a lot of questions. I know I've had some messages. Are you going to answer my question? I have 17 questions that we didn't get to. So I'm so sorry, guys, but we did get through 23, which is good. So please come back next week and post those in the Q&A. Again, that's the best place for us to manage those. I try to go in order as much as we can. Sometimes they get a little out of order, but I'm going to see if there's any that we can handle on our own. Cheryl, you probably have another call right now.
I do. And I was just going to say, Bonnie asks, is there a replay? So there, you can find it on bartonwebinar.com. You can go to our YouTube channel to find the replays. And this is our 70th issue, so you could binge watch.
Yes.
Yeah, over the weekend.
Okay. All right. I'm going to look through these questions. If you need to go, Cheryl.
All right, I gotta go. Thanks, Leslie.
Bye. Let me see here. Oh, you guys had such great questions here. I'm so sorry we couldn't get to more of them. Come back again next week. You know what? Can you guys hit the raise your hand button if you see that raise hand button on here, if you will be here next week? Because if you are, I may adjust our schedule to just do your questions. Because if we have this many, I would really like to get through a bunch of these. So hit the raise hand button. So I know you'll be here next week, same time, same place, so that we can just do questions so that we can get through a lot of them. So quite a few of you. Okay, we may do that. Come back next week, post your questions right away in the Q&A. We'll get to as many as possible. What I'd recommend in the meantime is to go to bartonwebinar.com. There's going to be a link to our YouTube channel, and go look at the Healthy Heart webinar playlist. You will find our past webinars. Like Cheryl said, I think you're going to find a lot of information there. Okay, it will really help you. Okay, thank you so much for being here, and